Well, you just spoke about something that's very positive. What is the most challenging part? Like I mentioned, your patient population, my patient population. The only, I can't think of too many patient populations that don't have aspects of it that are very challenging because some patients are harder to help than others.
Sure.
For a variety of reasons. What's the most challenging part about your profession, your job?
So with pain management, I mean, there come a lot of hurdles. Of course, they're extremely grateful. I love my patients. I couldn't wish for a more rewarding job. At the same time, it's got its challenges, and like what we're dealing now in the United States is obviously an opioid epidemic. We're all aware of that. And so when it comes down to prescription of opioids and narcotics, I think is the biggest challenge. Catching somebody that is almost fabricating their symptoms for a secondary gain of getting opioids, or catching a patient who's failed a urine tox screen, or for example, whose urine toxicology screen comes back negative. What are you doing with these opioids that I'm prescribing you? You're putting my name and license in risk. So these are some of the challenges that we face because we get a lot of seekers for opioid medications, and confronting that patient. And not just the patient who's fabricating symptoms, it could be the patient who's got legitimate symptoms who thinks opioids are the way to salvation. Just because they've been put on a fentanyl patch or they've been put on these hard opioid medications from providers who, either didn't know at the time that, what Purdue Pharma's actual agenda was, that didn't know that oxycodone and OxyContin can cause serious addiction issues that have now led to the current opioid crisis. I mean, why is it that 75% of the world's opioids are consumed by people in the United States? Is it because of misinformation? Is it because of Big Pharma's hand in all this? I think that's probably the hardest part of my job is kind of working through the algorithm of how to treat certain patients with certain opioids and where to draw the fine line. At the same time, you don't want to undertreat. That's a big problem too, because now the pendulum is swung the other way where doctors don't want to give any opioids. Is that the right thing to do for somebody with chronic cancer pain, for example? Absolutely not. It's one of the recommendations and algorithms by the FDA and the DEA. Somebody suffering from cancer pain, you should definitely try to treat, and opioids are indicated. Now, this is where it gets a little hazy. You don't have cancer pain, you've got chronic pain, you're not a candidate for surgery and nothing's working. What do you do at that point? And I think that's where new education, understanding where these new age drugs are coming into play, understanding where ketamine has its role, understanding where some of these new partial opioid receptor agonists, antagonists like buprenorphine, Suboxone, Belbuca, where these drugs come into play. So you definitely have to be up to date. You can't, in pain medicine, you can't sit back, kick up your feet and just, hope for the best and prescribe opioids. You really got to be up to date and know what patient needs to be treated with what. You can't say no to all. You can't say yes to all. So I think that balance right there is the hardest part of the job for sure.
Have you noticed, because I tend to watch the trends, the news and online, is there a decrease in the amount of news coverage of the opioid crisis past 6 months? I just haven't heard about it like I used to. It was just like 2 years ago, maybe 3 years ago, before the pandemic, where it was all over the news. Now I don't hear much about it at all now.
You bring up a good point. I think since former President Trump actually declared it an endemic to the country, ever since then, it's kind of dropped off in the news. But what's kind of taken over have been these increases in spikes in fentanyl overdoses and deaths.
Okay.
So I think that's kind of slowly crept in and take over the opioid epidemic, because now that we're not prescribing as much, I think patients are looking for other alternatives and looking on the black market. And you'd be surprised how many times I've had patients threaten me. Well, you know what, doc? If you don't give it to me,
I'll go out.
I'm going to go out and find it myself.
I know. Yeah.
And so, that puts a lot of stress on a provider, especially when you're seeing 30, 40 patients a day. You got sometimes 15, 20 minutes with somebody. Good luck allocating 20-minute slot to telling somebody, look, I don't want you to go do drugs, but I also don't want to give you opioids because that's not what's indicated. So nevertheless, I think we're seeing a big spike now in fentanyl overdose, fentanyl deaths. And it's, there's a lot of theories as to why. Is it because it's so cheap to make? Is it because it potentiates or it increases the activity of other medications like benzodiazepines and Xanax and all these other medications where it's cheaper to make with more of an effect? Well, I mean, drug dealers aren't the best laboratory scientists. So a little microgram here and there can stop somebody from breathing. And I give fentanyl all the time in the operating room.
Mm-hmm.
And 12.5 micrograms versus 25 micrograms might stop somebody from breathing. Well, luckily, they're on a ventilator. So I see this all the time where I'm tracking their respiratory rate. And even the smallest micro adjustment in fentanyl will stop them breathing if they were on a ventilator. So people need to understand that use of illicit drugs, it's dangerous now because things are spiked with fentanyl, and that's really, really scary. So to your question, I think there has been definitely a drop-off in coverage of the opioid epidemic. And I think part of that is because Purdue Pharma finally went under fire and the family got, sued, and they paid the families, some of the money that was due. And I think that kind of dropped off some of the news reports. But at the same time, the fentanyl spikes and fentanyl deaths kind of took over that pretty quickly.
That's such a tough conversation to have when someone comes to you for what they think is help and you disagree with how they plan on helping themselves, which is a prescription. I guess the difference between a drug dealer and a doctor oftentimes is our willingness to say no and try to find some other way to help.
Yeah.
I mean, I feel for our profession, I feel some level of guilt because it was doctors who took part in the creation of the opioid epidemic. Again, you mentioned some doctors didn't know, some did.
Correct.
And that's some of the guilt that, I is transferred onto me sometimes when I see or hear about patients that are like, stuck on opiates. They started off with a pain issue, very mild. The doctor gave them too many opiates and now they're hooked on it for life.
Yep.
That's just kind of rough to hear.
It's very hard to hear. It's hard to see them come through the door when they're on such a high script. And sometimes they'll be discharged from other clinics and they'll come to me and saying, look, today's my last day. I got 7 pills left. I take 7 oxycodone a day. I need help.
Right.
So you got to just have a frank discussion with expectations and let them know, look, I'll fill your script for this week. Next week, we're going to start coming down and I'm going to transition you to something else. I think that effort is getting harder to find at a doctor's because it does take effort. And the way medicine has become corporate and the way we've lost this connectivity to the patient just because of how reimbursements have been going and how patients are now turning medicine into more of a volume game as opposed to an individualized care game has unfortunately led to less of a one-on-one interaction, and which translates to less effort. And when you mix pain medicine and opioids with less effort, that's a bad combination. And so I am seeing more and more patients almost quote unquote dumped off with high levels of opioids. But luckily, we've got so many tools in our toolbox now, like with these partial opioid agonists and ketamine and all these things that help us mitigate using such high levels of these pure mu receptor agonists like oxycodone, Vicodin, narco, fentanyl, et cetera.
Right. Like, where are we headed with all this? Are things getting better? Is it ever going to end? Like, where are we headed in the direction of like treating this crisis?
I think there's a lot of variables to consider. I think the simple answer is no. It's not over. I don't see it being over in the foreseeable future. The reason for that is as long as big pharma's around, there's always going to be a secondary or hidden agenda with medications. Now they're trying to do a good thing in, pushing new medications out that are not primary mu receptor agonists like the ones I just mentioned, that are partial agonists that don't have that sort of level of addiction or affinity or whatnot to the receptor, thereby making it less likely for somebody to get addicted, for somebody to develop tolerance, hyperalgesia, which is an increased sensitivity to pain. So nevertheless, I think as long as there's big pharma, it's going to be very hard to push primary opioid receptor agonists out of the equation. I think there's always going to be a role for these medications, certainly in treating patients that have chronic pain that are not good candidates for anything else. If you've tried a bunch of different approaches to the problem, but at the same time, unfortunately, I think the change in medicine and it becoming more corporate is going to lead to less effort in doctors individualizing care. And it's either going to be a hard no from a doctor or an easy yes from a doctor in regards to an opioid script refill. It really does take a lot of effort to have somebody come down on their opioids and transition to a different medication. Not only effort, but care. You really got to care to do that. You can't be cold to the patient. You can't be non-sympathetic and apathetic to their care, because they're going to see that and they're just going to walk out and say, this guy doesn't care, you know? So pain management's it's an interesting field in which pain is a very subjective feeling. Some practitioners call it almost the fifth vital sign. You know, you can objectify it, but it's hard to do so, especially having patients understand that it could be objectified. So as a pain practitioner, you really have to be sympathetic to the patient and have them understand that you care. And that's where we are almost running into trouble with the corporate medicine and how insurance has kind of come into the mix. But there's still hope.
Yeah.
I don't think that I don't like to lose hope, and I think there's a lot of hope left for young doctors to kind of change how the system is. But it is a shame that 80% of the world's opioids are, you know, taken up by the United States of America.
Well, there's lots of other countries in the world that barely use opiates at all. We use them all the time. It's very easy to get a prescription after something as simple as your tooth being removed. You can get like a prescription of opiate medications. It's not difficult. Whereas other places in the world, no, you just kind of deal with it.
Right. And I think you bring up I'm so happy you just said that, because it's interesting how insurance companies play into this. I will get an easy authorization for oxycodone or hydrocodone or Dilaudid, which is hydromorphone. I will get it easily authorized by the insurance company. What I won't get authorized, what's really hard to get authorized, buprenorphine, which is the new up-and-coming drug that helps patients get off these medications, that helps patients deal with their pain, their chronic pain, by not using hard drugs like Dilaudid and fentanyl and hydrocodone. So it's very interesting how insurance companies are just authorizing these really difficult, medications to take or wean patients off with all these side effects, and not authorizing the ones that can actually be really beneficial. Drugs that are beneficial are super expensive. Why is buprenorphine or Lyrica or pregabalin $300 or $500 a month when it can change this patient's life?
Right.
Why is oxycodone $8 a month at Rite Aid? It just doesn't make sense the way this has all become so bureaucratic and corporate. So I think that also has an effect on where we're headed to. It's unfortunate, but like I said, as long as the practitioner cares and they're willing to make that effort, there's definitely hope.
I mean, what you're kind of describing is a cultural shift. One issue that I know you might agree with is the fact that we don't really practice prevention in medicine whatsoever. We just we're better at treating things after it already happens.
Yeah, we react.
Yeah. We're not all that proactive. Mm-hmm. And again, that's more of a cultural shift. And I don't know how much the higher ups that teach us medicine are playing a role in it. I don't know how much the drug companies are playing a role in it, but I do think that the upcoming doctors, I mean, you and I both just graduated pretty recently, within 5 years, 2 years, 3 years ago. So I think the newer doctors are going to have a different mindset.
I hope so.
Coming in.
I think so. You're right. You're right, because I mean, part of that different mindset is going to be, how you get trained and what you see throughout your training and residency and med school and all that. And I think there is a gradual shift. And, the ones that are coming out of the training are going to have that sort of experience, and that's what they're going to take onto their own clinical practice. That's very important.
It's our culture.
It is the culture for sure. I think it's probably a little different in Europe in terms of like this holistic approach. Like in Germany, for example, treating patients with opioids, forget about it. You won't even get an opioid for surgery. You'll get hit with a bunch of different medications. You'll get hit with ketamine. And you'll get hit with Tylenol, you'll get hit with Toradol, all these different medications, but you won't get hit with opioids. And they'll use a lot of these opioid-sparing modalities. They'll do, like, for example, if you're getting a knee replacement, you'll get a nerve block, or you'll get an epidural. In the United States, you'll have fentanyl sitting in your drawer, and you'll push a couple micrograms. But I'll never forget, I had an attending during my training. He was great. He had a lot of combat experience, but he loved pushing an opioid-free agenda, And that kind of opened my eyes up because I was like, wow, I'm getting patients out of the OR up and moving, and they're in as much or in as little pain as my other patients are with using opioids, you know? So it's interesting. There's a lot of ways you can reduce opioids. I just think it's a cultural shift, like you said. I think Big Pharma's definitely got its hand in there. I think the hospital systems are looking for cheaper ways of discharging and cheaper ways of getting patients out the door and keeping them comfortable. They want to keep their satisfaction scores high. So you definitely you don't want to discharge anybody with a little bit of pain. You want no pain when you discharge them. So there's a lot of things that come into play when you really think about it.
That's true. Yeah, it's very weird being in a country that's so forward thinking, but also so backwards and slow. It's hurry up and wait. It's just kind of.
It's like one of my anesthesiologist attendings used to say. We used to wheel the patient on the gurney into the operating room, and a surgeon's waiting, and we want to get the patient on the operating table. So he'd be like, "Hey, buddy, all right, take your time, but hurry up." It's one of those.
That's how we
take
are
your time,
here.
but hurry up.
Yeah, I mean, if you even go as far as the freaking metric system, why haven't we switched to something that's way more efficient? We're just kind of stuck in our ways.
Yeah. How many feet is a meter again?
Yeah, I don't know. Why does it matter?
I don't mean to put you on the spot.
Why does it matter?
I think it's up on that board, maybe.
I think it's 3. Is it 3?
Yeah.
Yeah, I had a feeling.
Sounds about right.
I know. Just wanted to be more American and just say, nah, it doesn't matter. We're all feet. Who cares about meters? All right, so we're about finished. Okay, so yeah, if you could plug your Instagram, plug how people can find you if they're interested in getting treatment with you, how can they find you?
For sure. I got an Instagram handle. It's Chronic Pain Doc. The name of my practice for pain management and where I perform my Stellate ganglion injections and ketamine infusions and just chronic pain in general. That's my pain management and injury relief medical center. That's PMIR. I also, I'm a co-owner in a medical spa where we offer different modalities of treatment, and that's called Renewology. And you might say, how do you have time for all this?
I was going to ask.
Ketamine. No, I'm kidding. But that's kind of where you'll find me. You'll find me pretty active on social media at Chronic Pain Doc.
Okay. Yeah. Awesome. Any other thoughts before we end?
Mental health. I think, to summarize, I've been very lucky to help people in need of mental health intervention. I don't think it's anything to be shameful about. The older I get, the more I realized how much of a role anxiety plays into everybody's lives, and so does depression. There's living in 2022 or 2023 now is not easy. There's a lot going on. There's the pandemic that we just survived and that we're still trying to survive. There's this fluctuation in the stock markets and the rates going up and down every day. There's our personal lives that we're trying to make happen and make ends meet. There's so much that come into play. And the older I get, the more I realize it's not easy. But at the same time, there is so much hope. There's so many treatments out there. Reach out. Don't be afraid. Don't sweep it under the rug. Because the more you do that, the more it's going to build. And the more you're going to build resentment against yourself for not taking care of it. So take care of your body and take care of your mind. Exercise. Eat healthy. I cannot stress how important exercise is. As little time as I have, I still try to get at least a treadmill session in.
Yeah.
So it's so important. I talked about those endogenous endorphins in our body. That's how we regulate those endogenous endorphins. That's how we regulate our own opioids in our body, is through exercise, and it plays such a critical role. So eat healthy, sleep enough, and exercise. That's the best thing you could do.
You should start a podcast.
Maybe this is where it starts.
Yeah, maybe. I can show you a few things. You can get yourself started.
Thank you.
All right, ladies and gentlemen, we're all finished. Y'all take care. Have a great day. No supervision. Signing off.